Happening right now, doctors at Mass General Hospital raising awareness about the recent uptick in RSV cases ahead of the holidays. Let's listen.
MGH. So our goal here today is to make sure there's a common understanding about what's going on with pediatric healthcare right now, particularly the inpatient bed crisis. So as many of you may know, the pediatric inpatient census at Mass General Brigham community hospitals, and all the pediatric hospitals in the state is at very high census and capacity, really exceeding the physical bed space and the staffing capabilities of all of our pediatric colleagues. And this has really been due to the circulation of a lot of respiratory viruses through the fall into now, through the late summer into the fall, now going into the winter. Really in the fall, we were seeing a circulation of rhinovirus and enterovirus. And these viruses were causing very severe respiratory illness in young children, leading to breathing difficulties or leading to asthma exacerbation. So there was a high degree of hospitalization occurring with those illnesses. On top of all that, starting October, there's really been exponential growth in respiratory syncytial virus or RSV infections. And that really has ballooned through the entire month of October. That has created enormous stress on pediatric healthcare because the need for hospitalization has been increased with that infection. Normally RSV is a circulating winter virus. It's very common in children. Almost all children who have seen RSV and been exposed to it, infected with it by the age of 5. And what's happened in the past 2 years with COVID is that a lot of the pandemic and the pandemic mitigations have disrupted the normal viral transmission of a lot of circulating viruses. And so a lot of RSV was not being spread in the previous 2 years. We've had unusual spread patterns and not as many peaks of spread of RSV. And so what we believe is that there's been a lack of population immunity in RSV. And so many of our younger children have never seen the infection. And so now that it's circulating a little bit more typically, there are many more people susceptible to infection. And the younger you are when you get infected, the more likely you are to have a more acute presentation. Our patients, the youngest patients, are at highest risk of needing hospitalization. Those are typically patients under the age of 1, really under the age of 6 months are the highest risk. And then pediatric patients with chronic conditions of childhood, like heart disease or problems with their lungs, may often require hospitalization. Usually those hospitalizations are brief, but it can be very severe. And so some patients may need breathing support in the pediatric intensive care unit. And so what's happening is there are a lot more RSV infections going on in the community, and a significant portion of those need hospitalization, and then a portion of those need hospitalization in the pediatric ICU. What we've seen actually at Mass General Brigham is around 2,000 cases of RSV in the month of October. In the first week of November, we've seen over 1,000 cases of RSV. So it's been escalating and been quite severe. Thankfully, most of those infections are being treated in our urgent care facilities, at our emergency departments, and most people are discharged home. But even if just 10% of those need hospitalization, it creates a lot of stress on healthcare facilities. And so what we are seeing is we've had over 250 hospitalizations for RSV alone, on top of the other circulating viruses. And so you may have heard earlier this month that a lot of our community hospitals are struggling to find beds for acutely ill patients, and that's really all due to these circulating viruses right now, causing increased need for ICU admissions. And so earlier this month, a number of patients couldn't get pediatric ICU beds and were being transferred out of state to other facilities. And so in response to that, the Department of Public Health convened the 5 pediatric academic health centers to get into weekly collaboration calls to ensure that we could meet the needs of the Commonwealth here. That's been very successful in enhancing coordination and communication with all the academic pediatric health centers, but it's really been a lot of discussion about the shared stress that they are all under. And all of us are full every single day. At any given time point, when you look in the morning, there are no available pediatric ICU beds. There are no available pediatric general care beds. And almost all of us are operating over capacity. Today in our pediatric ICU, our ICU is completely full. We actually have 7 patients that are outside the pediatric ICU that would normally be transferred into the pediatric ICU, but we are forced to care for them out of the traditional ICU setting. This is really only possible through the dedicated efforts of our physicians, our nurses, and our respiratory therapist colleagues, and they're really making what would normally be impossible possible right now. But our community EDs are still going to be stressed, and they're still looking to get the care they need for those patients. We've been working with the DPH on a number of things, and we've been really trying to enhance the pediatric staffing and using all available pediatric physical bed spaces in our hospital, our community hospital, in all the hospitals in the state. That is always going to be difficult because our pediatric healthcare providers are also getting ill, so we can't always staff at 100% physical bed capacity, and there is a healthcare staffing crisis. We are trying to utilize our relationship with our adult hospital here to admit older patients to the adult units. So in alignment with the Commonwealth of Massachusetts regulations, patients over 15 can sometimes be cared for by adult colleagues, and we are sometimes using that and collaborating with our adult colleagues here to admit older pediatric patients into the adult units. And that's been working very well, and we've had great collaboration with our adult colleagues here. Our neonatal intensive care unit usually admits patients soon after birth or with extreme prematurity, and they really have stepped up to the plate here, and they are admitting older, what we'll call older neonatal patients or young infants into their unit, and they've really helped us try to offload some of the capacity issues we're experiencing. But they are also full every single day. We have been trying to support our community with telemedicine support, and so we've been standing those up for all our community hospitals, and we are working with them every day to try to keep patients in the community when appropriate. In accordance with the DPH, we are also standing up high-flow nasal cannula protocols, so these are ways to give more oxygen support in the community and EDs and on general care wards everywhere, and we hope this will keep more patients in the community and less stress in the pediatric facilities. Then lastly, we are forced to review our procedural volume every day to see if we can meet the needs of patients needing post-surgical care. Unfortunately, with all the viral admissions, we simply do not have the physical bed space and are not able to make them to meet the procedural demands. And so we have been, unfortunately, been forced to cancel some pediatric surgeries this week to the great disappointment of our staff and our families. But that is an unfortunate reality right now because we have to make difficult decisions about where to place patients. So overall, we are experiencing a lot of RSV infections. That's on top of other existing viral infections. And we are stressed every day. I want to point out that to respond to this requires a lot of collaboration with Mass General Brigham, with the state and federal authorities. And so my colleague, Dr. Bittinger, is going to speak to that in a moment. But first, I just want to talk about the general care of viral illnesses. 99.9% of pediatric patients with RSV are going to get better. But they do need transit support, and sometimes they need ICU support. Most of them can be safely cared for in the community or safely cared for as outpatients. And to speak to that, I'm going to invite my colleague up to the podium, Dr. Alexia Rose-Boudreau, who will speak more to that point. Thank you.
Good afternoon. My name is Alexia Rose-Boudreau.
How you doing?
I'm well. Always on the shorter side.
Doctor, would you mind spelling that while they adjust the mics?
A-R-A-U-Z space B-O-U-D-R-E-A-U. I'm an associate chief of the department and a primary care pediatrician at one of our community health centers. I am also a mother of 3. What Dr. Cummings has described is really unprecedented in my career as a pediatrician. At the same time, I also know that respiratory illness is something that we go through every single year, and most of our children will be fine. What is important is that we monitor them. We see how they're breathing, how they're playing, and if we start to get concerns that they're tired at rest, working harder to breathe, or not drinking enough fluids, that's when you call your pediatric office. And for the most part, we can manage it, staying at home, resting, drinking fluids, and controlling people's fever. Now, why is this happening now? Well, over the last 2 years, our children really haven't been exposed to the routine viruses. And now that they're no longer masking or social distancing, their immune systems are encountering new viruses and is responding the way we would typically expect it to respond.